I'm not sure if this is a trend in other countries, but I come from a very small country, a little post-socialist republic. And and I work at a psychiatric clinic, and very often when you talk to physicians, when you bring them up to do a presentation and they don't have a better idea of what to do, they do this horrible, sorry?
Can you use the microphone?
Yeah, sure.
There's a fan running.
Can you hear me? Yeah. So there's this horrible genre of presentation where they just talk about their department and tell how many patients they see and how long they work there and how much money they have. So I thought maybe I'll try to take that genre and make it good. So I'm gonna do something different from the rest of the talks today. I'm gonna take a sort of high-level account of how we in a psychiatric clinic are trying to integrate some principles of enactivism, specifically neurophenomenology, into the clinical practice. And then I can go on for a very long time. Oh yeah, this is since I'm doing biomedical research, I have no conflicts of interest to declare. I'm a public servant or a parachute of the state, depends on your perspective. So I work at the Laboratory for Cognitive Neuroscience and Psychopathology, where we've just opened something called Department I1. So that's a department for the study and treatment of treatment-resistant disorders, specifically depression and schizophrenia, and then here and there we get some complex trauma as well. This stuff has been operational since 2020. We've gotten some interesting grants from the Republic of Slovenia, and we've recently got an ERC grant, and the main point is to try to use these interdisciplinary approaches like neurophenomenology to tackle stuff as treatment resistant. So there's here's a bunch of stuff that we do. We do personalized treatment, we do interventional psychiatry, which I'm going to talk about in a hot second. We do psychotherapy, we do neuromodulation, and we do use some novel medication like esketamine, and we're currently waging a legal war against our government so that it would allow us to use psilocybin for medical research in Slovenia. We're winning, by the way. So the foundational principle that we've kind of set this whole thing around is this idea of interventional psychiatry. There's a lovely paper by Taylor and colleagues from 2015. They call to move beyond neural cubism. And so they say that what happened tragically is that, like a cubist painting, our understanding of the mind, especially within psychiatry, especially within how psychiatry is taught, has been split into these various disciplines like endocrinology and neuroscience. We have psychiatry, psychology, psychopathology as a semi-independent field, and they all have a more or less different view of what we're trying to deal with here. And so this is often a problem in clinical practice. So this is the results from something that we were doing. So we had patients with treatment-resistant depression. We treated them with TMS. We did some brain measurements. This is an ERP from measuring working memory. And so we can describe these patients really, really well on a neural level. We can take EEG, we can take MRI, and we can diagnose them with something like disconnectivity, right? Frontoparietal hyperconnectivity most commonly. And then we can also take some subjective measures, measure symptoms like IDS measures depression, LAPS measures anhedonia, things like that. And we can also describe them really well like that. And then we treat them with TMS. And we see differences in both of them, but the problem is that we can't really relate the neural stuff to the symptomatic stuff or to the phenomenological stuff. So this is a real challenge that we see on a daily basis. Just very quickly, if we look at the history of psychiatry, we had three major sort of paradigms. The first was sort of the focus on the symbolic content of a disordered mind. This is what Freud did, interpretation of dreams, such and such. The second was this big psychopharmacological approach, where we try to understand all disorders as disorders of neurotransmitter systems. This is still very popular, still quite successful. But there's a new emerging paradigm, which we can call it this neurocognitive network paradigm, where we're trying to identify psychiatric disorders as disorders of these neurocognitive networks. And with that, we're trying to there are all these kind of attempts to describe patients, not in terms of these diagnostic clusters of descriptive problems that they have, but we're trying to move towards understanding psychiatric disorders as these deviations on an underlying dimension of some form of human functioning, right? And so here we get into this neurophenomenological discourse where we no longer talk about multiple levels of analysis, we're talking about multiple units of analysis. Research domain criteria is like a methodological framework that's sort of most well developed, where you can look at blood work, and you can look at phenomenology, and you can look at some neurocognitive network, and you understand these as sort of different angles of impact on the same biological process, at some level being explanatorily more fundamental to another. And then in 2020, Scientific wrote this lovely book, which kind of shaped the whole direction of our department, which is called Enactive Psychiatry, where she kind of enriches that, but by taking this other dimension, not only these typical ones that we usually talk about, she calls it the existential dimension. So we can, it basically means that we can take an attitude towards our own lived experience, and then that psychiatric disorders are very commonly disorders of this specific attitude. But what's more important from my perspective is that she proposed a specific methodology, which we refer to as the personalized network model approach, where the idea is you take a patient and you describe them according to these various dimensions of their functioning, you elaborate the relationships between these aspects, and then ideally, you're going to find out within this complex network of interactions, something that's amiss that can be treated. So Sean Gallagher this year published a really lovely book that kind of shed light on the things that we were doing. But even before that, what we started doing is we started creating this very large database of well-described psychiatric patients. And for each of them, we tried to construct a personalized network model. We follow patients typically for a year, and methodologically we use a combination of descriptive experience sampling, which just means that people are, they have an app on their phone and it beeps several times a day to report what they're experiencing. We combine that with phenomenological interviews, and we do sort of rigorous neuropsychological testing as well. And so the term that we've developed is that we're trying to find what we call a critical pattern. There's something that there's going to be a loop typically in this personalized network model that is related to the etiology and maintenance of some specific pathology. Typically, this is some maladaptive cognitive process, but I'm completely open to other aspects to come out as relevant. But so far, we were able to identify something wrong with cognitive information processing, stuff like that. We've talked about that. I'm going to skip how you analyze interviews because that's not super relevant. But what is relevant, I think at some point today we had some talk that sort of strives to be atheoretical. Whenever we're constructing these nodes and connections with them, we're really trying to build on the data we get from the patient. We try to bring as little of sort of theoretical background into it. And this is not relevant as well. So this is kind of the four directions that we typically go into. We have, phenomenological psychopathology, something's wrong with the patient, they have some problem, and we try to describe that. We're always thinking on the one hand in terms of biological mechanisms, that's usually related to treatment. On the other hand, because we have to get scientific grants and do experiments, we try to extrapolate some cognitive mechanisms to that. But the underlying question is always, how can we use this wealth of data to offer better treatment to our patients? So first, let's look at the phenomenological psychopathology and knowing myself. We won't get to others. So this is a case from the first time we tried doing this. This is work that's mostly done by a very talented student of mine, Aleš. She followed this patient for 2 years now. And the patient is a 26-year-old woman, and she has a diagnosis of borderline personality disorder. And in the last year, she underwent 8 highly unsuccessful treatment regimens. The case is really, really problematic because she engages in really gruesome self-harm, and also she's abusive towards her partner. And so there's this, typically, this patient will come to the clinic either because she harmed herself or because she harmed her partner. And there was this, we were really stuck. We didn't really know what to do with her. And so my student followed her for a year, and she identified a specific critical pattern, which you can see there as the purple line, which is that phenomenologically, the patient was experiencing this profound lack of sense, which is sort of very typical for borderline personality disorder. But the way it manifested was that she obsessively read it about different pathologies, the different psychiatric diseases. And then she went to a psychiatrist, lied to them what her symptoms were based on what she read on Reddit, got prescribed medication that wasn't appropriate, that didn't help her symptoms. It deepened her sense of self, so I forgot what I was going to say. It deepened this lack of self that she had, and then the cycle repeats, right? And so she was stuck in this loop. And then now going forward, the main therapeutic approach is to kind of examine this need to have a diagnosis, this need to lie to psychiatrists, stuff like that. So this was the first main, this was the first time we sort of did this successfully. I'm very happy this is accepted for publication. That happened last night, so this is very exciting. We had this really interesting case. We're anonymizing him as Hernan. He's a 27-year-old man, and he presents with a really complex set of comorbidities, has anxiety, depression, very psychotic, and has this really, really severe obsessive-compulsive disorder. He's highly intelligent. He's finished, I believe he has 7 degrees. He self-harms a lot, mostly due to these persistent imperative auditory hallucinations, and he's highly socially dysfunctional. One aspect of his social dysfunction is that he will spend most of the money he has each month. He gives it away to waiters as an apology for having to bear his presence there. So he has these huge problems. And so the image to the right, we've tried to describe this core pathology that he has. It's very familiar to anyone who's done work on obsessive compulsive disorder, which is that he will place some food in a microwave, close it, and then he will be able to access in his working memory that there's no spoon in the bowl. But he doesn't trust that information. So he opens it and tries to recheck it, and closes it again, accesses this information, doesn't trust it. So what we did was, the personalized model there is to the right, and there you'll see all points going to the right bottom thing that says who, which I've termed in a very pretentious manner the crisis of objectivity. There was this is the critical pattern that we see in Hernan, which is that he is unable to trust any information that he appraises as coming from himself. That can be working memory, that can be some social intuition. For instance, if you check your experience of any interaction in a given moment, you don't really know that the person you're talking to likes you. You have to have this sort of faith that they do, or you can ask them and check. For Hernan, all of this was completely impossible, and it was completely crippling to his life. And so this was now a year and a half ago. We specifically designed some psychotherapeutical interventions. At some point, I've had him read Kierkegaard and his idea of a leap of faith. And so we've tried to foster this faith in the world, faith in other people, and that has been highly successful. So this is, we've successfully helped him out in some way, and in some other ways, we're still trying to find a way. What's interesting is that just before I came here, there was a new patient that came to me who has recorded everything about his life for the past 25 years in Excel spreadsheets. So he has every page of every book that he has read recorded in an Excel spreadsheet, every meal he's ever taken down to the gram of protein that he's taken, and every time he has a bowel movement. So that's the information we have going back, decades. And based on the brief interactions I've had with the patient, it seems to be kind of the same thing. He needs to have like an objective representation of his life to be able to successfully function. So now a question going forward is, can we use some stuff that we've learned with Hernan to maybe speed up the process with this specific patient? That remains to be seen. We can do this on the level of groups. We're currently, as I mentioned, trying to do psilocybin research. Thank you. And so here, the conversation is much more difficult because if we look at the biomedical research on psilocybin, especially psilocybin microdosing, it doesn't seem to work. But then we did this large-scale study. We've used this methodology to follow people who, for whatever reason, engage in microdosing. And so what was actually two things came out as really interesting. The first one was that the presence of negative side effects was alarmingly large. And when we compare it to what's reported in the literature, this was a huge discrepancy. And so we're thinking that it's the double methodology because we used sampling. And typically what we see is that in the moment, participants report psilocybin microdosing is horrible. They have their stomach is hurting. They're overwhelmed with thoughts. All the social interactions are super intense. And then when later on we do retrospective debriefings, like it was a great experience, it was fantastic, my imagination was really, really great. And so we're thinking it has something to do with this bias brought in by retrospective reporting. But then the second thing that seems to be happening is in these detailed microphenomenological interviews, we can see that the actual changes in conscious experience across participants are super similar. But then, depending on their previous experiences with, say, psychedelics or with mental health disorders or with meditation, they ascribe very different conceptual frameworks to that experience. So we're thinking that that's something that would be worthwhile looking into. I'm going to skip the biological mechanisms, or maybe that's not. This is kind of interesting. This is work that's being done by Leon Groschitz-Rudnick, who's a fantastic genius psychiatrist who I love. One of the things that we're trying to tackle with this approach is treatment-resistant schizophrenia. And in particular, we're focusing on clozapine-resistant schizophrenia. And so we've been, again, trying to throw all of this methodological machinery, and here we've included gene testing on figuring out why, patients develop treatment resistance. And so we've come into two mechanisms. So this is based on two case studies that we're now trying to evolve into a proper large-scale study. One is that there seemed to be a deficiency in the expression of genes related to adenosine expression, adenosine processing, which kind of then leads to this kind of, they don't metabolize the clozapine quickly enough. And then the second thing that we're now trying to do is we're using a combined TMS-EEG to kind of evaluate secondary deficit. Because both antipsychotics and psychosis itself can present with motor dysfunctions, and then using TMS-EEG, we can time the speed of processing, particularly in the spine, to kind of figure that out. And then phenomenology was used, and this is the latest stuff that we're doing, which seems to be the experience of hyperfamiliarity, what some philosophers refer to as veridical knowledge, that seems to be in some way related to this maintenance of psychopathology. Cognitive mechanisms. Someone before was interested in demand characteristics. I think I'm going to do that in a minute. Let's see. So one of the things that we're trying to do is treat affective dysregulation with TMS, and we've actually had super low success with that. One of the things that I then tried to do is, emotion studies typically use these static images. There's like a horrible low resolution picture of roadkill or something like that. So I did interviews on how people experience those images, those types of tasks. And so expected phenomenology would be something like, you see a picture and then you have an arousal and you regulate it away, right? That's a reasonable thing to expect. But then the phenomenological interviews revealed that for most participants, both from the normative population and patients, what happens is that the picture has no honest emotional impact on them, but they kind of fake it in their mind. There's a lovely Slovenian expression, which if I translate it poorly into English, is that they construct a vibe. And so, and then the other thing is that there is this knowledge, emotions have knowledge, so this is just something that came out of it. Just a minute and then I'm done. And then what we kind of saw is that the more knowledge you gain from a stimulus, the higher is the emotional arousal. And so recently we just finished with a large scale study. We've shown participants positive and negative images. And then we collected data on arousal, valence, and degree of sense making. So how much knowledge they gain from the pictures. And we controlled for expectancies with phenomenological control scale. And what we see is that there's a totally clear relationship between phenomenological control and arousal, both for negative and positive stimuli. And then we also see that sense making is correlated in both negative and positive valence with arousal. And for patients, what we see is that there is much less sense-making present, which correlates with lower degrees of arousal. And so basically what we're thinking about here is that the tasks that were used to measure the neurocognitive networks that we're now trying to fix with TMS were sort of non-valid. And so we're trying to think about the efficacy of TMS or lack thereof through this lens of the neurological validity of the tasks. Had some other stuff to talk about, but I'm out of time. This is the team, Eurobond, the genius boss, who is supporting me, bunch of doctors, Leon Hudnik, the cool kid to the right, who is our great clinician, Anya Lepucic, our resident phenomenologist. And I thank you very much for your attention right now.
From the psychiatrist himself.
Yeah, thank you very much. It's a really interesting approach to sort of perhaps being a little bit more objective about the way we combine information into these networks. I guess one of the difficulties might be that the sort of patients that were reported there tend to be more on the obsessive spectrum, so they're more likely to report back when you're asking them questions, and presumably doing that quite actively. How do you manage the patients, for instance, for instance with schizophrenia, where they'd be much less likely to engage in that sort of reporting?
Yeah, thank you for the question. I think that's a really, really relevant point. Yes, with the obsessives and the obsessive compulsive, it's very easy to get really clean data. So with psychosis, what we find is that it's really beneficial that they're not approached by a clinician, but we have researchers who sort of kind of they hang out on the wards, and then they gradually develop a rapport and they start communicating. You learn the little logical missteps that they do, and so that kind of makes the conversation go more easily. And so we find that that was kind of the main thing, is that there's this formal relationship between a physician and a patient, but then with the researchers, typically we encourage them to go out into the yard and have a smoke with the patients. And then through these informal relationships, you get these really interesting data, which of course, you can do a microphenomenological interview with a patient who's psychotic. That's not really viable, but there are still other kind of methodological tricks that you can use to do that,
yeah. Fantastic. And just make one other small statement, which is that I think what we find often in psychiatry is that the thing that's actually a treatment is when the clinician has enough of a focus to understand the person's needs and sort of hold them in a sense. And I guess this is one way of formalizing that a little bit, that when you're sort of making those networks, you have to develop an understanding that a patient then reflects on and says, oh, I'm contained by that. So it's yeah, so I guess it's both a positive and also maybe a note of caution that we shouldn't believe our methods too much, because sometimes the interaction itself is the important thing.
Yeah, that's absolutely true, but that's why we kind of use this multi-method approach. So we try to use objective measures whenever possible.
This is going to be short. So it was a great work. I really loved it. One small question is, so you said integrating psychiatry and enactive cognitive science, and which part of it is enactive? I see that you drew on Simon Kiddehan's concept of existential stance, but I think there are more, seems to me that's more like the the latest development of enactivism, more core principles, maybe something like autonomy, how cognitive structures develop out of sensory motor interactions. Are these elements doing any work in your structure? So what's the enactive color of your framework?
So if I'm being completely honest with you, so someone before said today that they kind of ignore the hand wave kind of problem of consciousness discussions. I'm pretty much the same regarding that. Basically, what the colleague before said, we find that including patients in these treatments kind of helps, and then we ignore the reasons why. So that's basically it helps us do better treatment, and then we're not really concerned with the philosophical minutiae of it. I know that sounds anti-intellectualist, but that's the honest answer.
Thank you.
I was just wondering, because when you use like a picture instead of a natural picture, like if I were you have like a picture from a cookie, and the picture of one.
That's for the purposes of presentation, because I like to make cute presentations. They actually saw horrible art surgeries, things like that.
Okay, but in fact, my question is, don't you think, because I strongly believe that when you use a picture instead of natural picture, and this may be a comment to the condition, it's just you can relate more to picture because you make scenario for yourself than if it's a natural thing of people. It's like others.
Yeah.
But what do you think about that?
I'm not sure this is going to respond to your question directly, but in this study where we sort of validated phenomenologically the images and compared them to phenomenological control, one of the things that came out as really salient is that a lot of these open access databases, I think IELTS is one of them, the pictures are completely boring, they're low resolution, and then we included into that data set pieces of art. So images that were created to elicit an emotional response, and they sort of had consistently higher arousal levels, and also they were not sensitive to this suggestion effect. So that's something to consider going forward. Is it really the best idea to use these bland images, or maybe we should do something like that?
Thank you for bringing this clinical perspective. I was wondering when you were talking about like the psilocybin microdosing protocol. I'm quite surprised actually that you mentioned that you were expecting higher levels of side effects and that you actually had none.
No, the opposite.
You had side effects.
A really high degree of negative side effects.
A high rate of negative side effects. Okay. So how did you go about? How did you proceed to determine the dose for the patients? Because usually, I think with microdosing, you would try to reach a subthreshold dose.
Yeah.
So did you have a protocol to progressively converge towards that?
So the doses that we used were extremely small. So adjusted for weight, they were all sub 300 milligrams. But nonetheless, we had this consistent negative side effects with people who were only taking 100 milligrams. So that was consistent across all doses.
We have time for one last question. 10-second question.
Just a follow-up. Did you administer the psilocybin or was it a naturalistic study?
So we're now in two phases. We had one study that was naturalistic, and now we're doing the first study where we're actually administrating it. And so that we have like preliminary results are coming in. So we processed, I believe, around 27 patients and participants so far. Yeah.
Thank you.